Hello everyone, and welcome to the Cardiology Podcast, Why We Do What We Do in Cardiology. In this audio series, we will discuss the practice-changing articles in cardiology from the past to the present. This is your episode for today.
In this episode, we will discuss the ARREST trial. The title is Expedited Transfer to a Cardiac Arrest Center for Non-ST Elevation Out-of-Hospital Cardiac Arrest, a UK prospective, multicenter, parallel, randomized clinical trial. This was published in the journal, The Lancet on August 27, 2023. The first author is Dr. Tiffany Patterson from the Cardiovascular Department at Guy's and St Thomas NHS Foundation Trust. The British Heart Foundation funded this study. The International Liaison Committee on Resuscitation had called for a randomized trial to assess whether expedited delivery to a cardiac arrest center reduces deaths compared with the current standard of care following resuscitated cardiac arrest. And the ARREST trial was designed. The ARREST trial was a prospective, parallel, multicenter, open-label, randomized superiority trial. Patients aged 18 years and older with return of spontaneous circulation, following out-of-hospital cardiac arrest without ST elevation in electrocardiograms were randomly assigned in a 1-to-1 fashion at the scene of their cardiac arrest by London Ambulance Service staff to expedited delivery to the cardiac catheter laboratory at one of 7 cardiac arrest center (CAC) or standard of care with delivery to the geographically closest emergency department at one of 32 hospitals in London. The primary outcome was all-cause mortality at 30 days, analyzed in the intention-to-treat population, excluding those with unknown mortality status. The secondary outcome was all-cause mortality at 3 months. Between January 15, 2018, and December 1, 2022, 862 patients were enrolled, of whom 50% were randomly assigned to a cardiac arrest center and 50% to standard of care. 20 participants withdrew from the CAC group and 19 from the standard care group, due to lack of consent or unknown mortality status, leaving 411 participants in the CAC group and 412 in the standard care group for the primary analysis. Of 822 participants for whom data were available, 68% were male, and 32% were female. The primary endpoint of 30-day mortality occurred in 63% of 411 participants in the CAC group, and in 63% of 412 in the standard care group. Unadjusted risk ratio for survival 1.00, 95% confidence interval 0.90 to 1.11, p-value was 0.96. 2% of patients in the CAC group and 1% in the standard care group had serious adverse events, none of which were deemed related to the trial intervention. The conclusion of the study was that in adult patients without ST elevation, transfer to a cardiac arrest center following resuscitated cardiac arrest in the community did not reduce deaths. The authors conclude that delivering patients to the nearest emergency department after presumed cardiac arrest without ST elevation is a reasonable approach, and has similar outcomes as delivering to a tertiary center in the UK healthcare setting. The ARREST study is the first randomized trial of immediate transfer to a cardiac center following resuscitated out-of-hospital cardiac arrest. The study found that there was no difference in short and longer-term mortality, 30 days as the primary outcome to 90 days as the secondary outcome, between patients who were transferred to a cardiac center and those who were transferred to the geographically closest emergency department. The findings in this trial are in contrast to previous observational studies of cardiac arrest centers, which showed a survival benefit for patients who were taken to these centers. This contrast in findings may be due to selection bias in observational studies, where patients with fewer comorbidities or a greater perceived chance of survival may be preferentially transported to a cardiac arrest center. Another possibility is that the treatment approaches at cardiac arrest centers are not significantly different from those at emergency departments, despite the higher rates of coronary angiography and other invasive support in cardiac arrest centers. The interaction of age with the primary outcome, 30-day mortality, was not significant in the ARREST study, but this may warrant further research into whether direct transfer to a cardiac arrest center may benefit younger patients. The findings of the ARREST study are not readily generalizable to more rural areas, where there may be competing risks of increased travel time to a cardiac arrest center, and potentially greater disparities in locally available healthcare resources. The ARREST study provides an important first step in understanding cardiac arrest centers' potential role in resuscitating out-of-hospital cardiac arrest. The results of the study are consistent with those of other trials, such as COACT and Tomahawk, which did not find a survival benefit with immediate angiography versus delayed, or selective angiography in the non-ST elevation population and hypothermia. Thank you for listening to this podcast, Why We Do What We Do in Cardiology. The information in this podcast is for general information only for medical professionals and is not intended to be a substitute for medical advice from a qualified healthcare professional. We hope you found this information helpful, and we look forward to seeing you on the next episode.